Hi, this is Andrea Kane, and I'm here with you for HIT 292 Reimbursement Systems. We are still on Chapter 7. This is video number 3 of 7, and we are going to be talking about the Hospital Outpatient Prospective Payment System. If you are in your textbook, we are at the bottom of page 154, and we're going to talk about how in 1983 Medicare first moved to prospective payment systems, but they were looking at inpatient hospitalization. It took them several years, but then in 2000, they managed to start rolling it out on the outpatient side. And so that's what we're going to focus on is the hospital setting for the outpatient prospective payment system. Some key terms you're going to need to know are APC, ambulatory payment classification, packaging, bundling, payment status indicator, outpatient code editor or OCE, national unadjusted payment, discounting, pass-through, partial hospitalization, and sole community hospital. So make sure you are familiar with those. All right. Hospital outpatient services include clinic, emergency department, ambulatory surgery unit. An ambulatory surgery unit means a same-day surgery unit that is attached to a hospital, has access to the inpatient and ICU care areas. It's not a freestanding ambulatory surgery center. So if you're thinking ASC, no, no, no. ASC is not included when you're talking about OPPS. The effective period is January 1st to December 31st. They use a calendar year, and it's updated yearly. They have reimbursement methodologies, fee schedule for ambulance, physical therapy, durable medical equipment, case rate, partially packaged when they're using APCs, and that's most procedures, services, and supplies. And then they look at reasonable cost for things like acquisition of corneal tissue, Hep B vaccine, those types of things. APCs are a classification system that groups together like procedures with like resource consumption. APCs are the outpatient version of DRGs, except they're different. On the inpatient side of life, hopefully by now you've learned that you only have one DRG for that hospital stay. On the outpatient side, you can have multiple APCs for one encounter. So watch out for that difference. But they do take procedures, they group them together and roll them up into APCs. Diagnosis does not play a role in the grouping because this is all procedural. So under the partially packaged system, you have packaging and bundling. Packaging is reimbursement for minor ancillary services associated with a significant procedure, and they're combined into a single payment. And they give you an example in 7.1 in your book at the bottom of page 156, where a patient is seen in radiology for an MRI of the lumbar spine with contrast. The contrast utilized during the MRI is an iron-based magnetic resonance contrast agent that is reported with CPT code Q9953. Under OPPS packaging, the contrast medium is considered a supportive service and is included in the reimbursement for the MRI of the lumbar spine. A separate payment is not made for the contrast agent. So that's an example of packaging. Now, bundling, this is payment for multiple significant procedures or multiple units of the same procedure or services that are related to an encounter combined into a single unit of payment. Bundling, an example do they give us for bundling? Yes. A patient is seen by her primary care physician for continued neck and back pain. The physician orders MRIs to be performed at the cervical, thoracic, and lumbar regions. The MRI of each region is an individual component. In other words, you do them separately. When these three components are provided during the same encounter, the payment for the components is combined into one APC, and that is bundling. So you can see what the difference is there. Bundling is those separate procedures that may be rolled together for a single payment. Packaging is where you have a procedure and you have some other things that come with that procedure that are rolled into it for a single payment. So make sure you know the difference between those two. A partially packaged system encourages hospitals to create incentive to provide efficient care and manage resources with flexibility, and incentivizes hospitals to choose the most cost-effective option when a variety of devices, drugs, items, and supplies could be utilized. It encourages hospitals to effectively negotiate with manufacturers and suppliers to reduce purchase prices for supplies and items. And I would say that that is an ideal situation, not always possible from my experience in the real world. It hopefully influences hospitals to establish protocols to ensure the necessary services are provided, but scrutinize practitioners' orders to maximize the efficient use of hospital resources. Payment status indicators. These are a code that establishes how a service, procedure, or item is paid in OPPS. Each code in HCPCS has been assigned a payment status indicator. This is they're assigned to all HCPCS codes, and they give you an example of this in table 7.14 in your textbook on page 158. So for instance, they'll give you the status indicator and explain the reimbursement method, and then show you a procedure or service example. So if you have a payment status indicator of B, C, D, E1, E2, those are an M. Those are all not reimbursed under OPPS. So just so you're aware, at least they weren't in 2018. But you can go out there and look at the patient status indicator. There are 9 SI categories currently used in OPPS. They include APC payment, per diem APC payment, comprehensive APC payment, conditional APC payment, composite APC payment, package payment, fee schedule payment, reasonable cost payment, and services not reimbursed under OPPS. And multiple HCPCS codes are reported per encounter, so you do have multiple SI per encounter, and you just want to make sure that they are correct. And they do go through the OCE editor and pricer, and most hospitals have what they call scrubbers that catch these discrepancies. But anyway, each HCPCS code can be assigned to only one APC. Each APC has the same components. The relative weight is a measure of resource consumption, and the national unadjusted payment amount is the total reimbursement amount. So CMS portion plus beneficiary co-payment portion. And this is all, let's see here. APC components. I think I've gotten ahead of myself again, sorry. Yeah, it starts with figure 7.11 at the bottom of page 159, and then goes into the next one. These components. This is on page 159. Each APC contains a title, payment status indicator, relative weight, national unadjusted payment amount, and national unadjusted co-payment amount, and a code range. You can see an example of that in figure 7.11. The relative weight is a measure of the resource intensity of the procedure or service. The national unadjusted payment amount is the product of the conversion factor multiplied by the relative weight unadjusted for geographic differences. And this is the unadjusted amount a hospital will receive for a procedure or service that is in that APC. The national unadjusted payment amount is divided into two components that has the Medicare facility amount and the beneficiary copayment amount. Both the Medicare facility component and the beneficiary copayment components are adjusted for differences in wage indexes. This is the only adjustment made to APC payment rates to account for differences among hospitals. 60% of the facility amount is wage index adjusted. The wage index amount for the facility location is based on core-based statistical areas determined in the IPPS update for the corresponding rate year. So you just need to be aware of that information. It's not something that's going to be on a test, but you're going to just at least want to be aware of it. So payment status indicator categories. This is at the top of page 160. These are some that you will run across on a fairly frequent basis. They represent services or procedures that are reimbursed by PPS methodology through APCs. So you've got G, which is pass-through drugs and biologicals, K, which is non-pass-through drugs and non-implantable biologicals, and blood and blood products is R, S is significant procedures, no multiple reduction, T is surgical procedures, multiple reductions apply, and U is brachytherapy services, V is clinic and emergency department visits. There are new technology APCs. Those were created to allow new procedures and services to enter OPPS quickly, even though their complete cost and payment information is not known. So you can, there's 82 new technology APCs, or at least there were when this was done in 2018. That's probably increased. 41 groups have payment status indicator S and are not subject to multi-procedure discounting. The remaining 41 groups do have the patient status indicator T and are subject to the multiple procedure discount provision. Now let's talk about partial hospitalization. This is status indicator P. This is used with outpatient behavioral health services. This is an partial hospitalization programs are an alternative to inpatient psychiatric care to patients who have an acute mental illness. They are provided by hospital outpatient departments and Medicare certified community mental health centers. And typically these are throughout the day. Someone maybe starts at 8 or 9 in the morning and goes till 3 or 4 in the afternoon, and then they go home for the evening, come back. And it may be 3 days a week, 4 days a week, 5 days a week, depending on what the program is. But these are typically under APC 5853, and as you can see there that there's a different price for hospital-based, or different reimbursement for hospital-based PHPs versus for community mental health centers. Moving on to comprehensive APC payments, this is status indicators J1 and J2, and these were developed with the goal of moving towards a fully packaged outpatient PPS. These are all-inclusive APC categories where a primary procedure is identified for the encounter, and then most other procedures, services, and supplies are packaged into the CAPC payment amount. The services that are packaged are adjunctive, integral, ancillary, supportive, and/or dependent services that are provided to support the primary service. And they give you an example of this in figure 7.12, where they have someone with a closed treatment of a metacarpal fracture, closed treatment of phalangeal shaft fracture, emergency department visit, x-ray of hand, and show you how that works through. There's also conditional APC payment for SIs Q1, Q2, and Q4. These are conditionally packaged only when certain criteria are met. And there are 3 types of conditionally packaged services. The first are Q1 or STV packaged items. This is when an ancillary service with a patient status indicator Q1 is reported on the same encounter as a service with an SI of S, T, or V. Then the ancillary services package. But if the ancillary service is performed without any service that has an SI of S, T, or V, then the payment is provided for the ancillary service. And they give us an example of this at the top of page 161 with a strapping of an ankle foot and an x-ray of the ankle. So claim number 1 has the strapping and the cast application. And claim number 2 just has the radiology service, level 1 imaging without contrast. Talk about Q2. If you look in your book on page 162, there's example 7.4. A patient's admitted to the ED for a possible hip dislocation. A hip x-ray with contrast is performed and shows a hip dislocation. The treatment's provided to put the hip back into proper alignment. The hip x-ray is assigned a payment status indicator of Q2. The dislocation treatment is assigned a payment status indicator T. Because the hip x-ray is conditionally packaged and performed with a T procedure, payment is only made for the dislocation treatment. Theoretically, the reimbursement from Medicare for the dislocation treatment should be high enough to cover the x-ray, theoretically. Emphasis on the theoretically. And that's just my pithy response from the real world. All right, Q4, let's talk about that because that's with lab tests. Example 7.5 is what we're going to look at here, I believe, maybe. Or maybe not. Actually, that goes into Q5. Sorry about that. So they don't give us an example for Q4, but those are conditionally packaged lab tests. Payment status indicator categories, composite APC state payment. This is really talking about when things are bundled together, the individual components of larger services into one payment. This covers 8 composite APCs, so whenever it falls into these APCs, it may be here for composite payment. It refers you back to table 7.16 for APC 8004 procedures, and those are ultrasound exam of the abdomen complete, ultrasound exam of the abdomen limited, ultrasound retroperitoneal complete, ultrasound transplant of kidney with Doppler, saline infusion, sonohistography, ultrasound exam of the pelvis complete, and ultrasound exam of the pelvis limited. And then they also tell us to take a look at 7.5. And that's where a patient with abdominal and pelvic pain sent to radiology receives several ultrasound services. Physicians order ultrasounds of the abdomen, retroperitoneal, and pelvis at the local hospital. Because all the radiology services performed for this patient are part of composite APC 8004, the facility will receive one APC payment for all 3 services using SIQ3. Well, what about package payments? This is on page 163 in your book. So as discussed earlier, the use of packaging and bundling is a major component of OPPS to identify procedure services and supplies that have been packaged into the cost and reimbursement for the APC with which they are most often performed. SIN is assigned. These items are always packaged. It's important to note that these services are covered under OPPS, but a separate payment is not provided for the individual service or supply. And they give us table 7.17 as an example. So anesthesia, repair of cleft lip, debridement of subcutaneous tissue add-on, injection for shoulder x-ray, harvest vein for bypass, hernia repair with mesh, biopsy done with colposcopy add-on, nerve repair add-on, hepatitis vaccine, adult intramuscular. Those are examples of package services that'll have an SI of N when it comes to OPPS. Services paid under a CMS fee schedule have SIA, so you'll want to keep that in mind. Another example would be mammography. So ambulance transport, physical therapy, mammography, those are based on a fee scheduled amount. We've already covered ambulance, so that's different. Medicare physician fee schedule is utilized for physical therapy payments, so they're not under OPPS is really all they're saying. Reasonable cost payment. This is SIs F, H, and L. These are a small subset of services and supplies that are reimbursed at reasonable cost. And so in the cost-based payment calculation, the hospital's specific outpatient cost to charge ratio is utilized. Reasonable cost is then calculated by multiplying the charge or the fee for the service times the cost to charge ratio. And they give us the examples of acquisition of corneal tissue, certified registered nurse anesthetist services, Hep B vaccine, pass-through devices, influenza immunizations, pneumococcal immunizations, those types of things. And note that they have here no cost sharing, so the patient's not paying for parts of those. Several supplies, services, and procedures are not reimbursed under OPPS, and these are SIs B, C, D, E1, E2, M, and Y. This is on page 163 in your book. They're statutorily excluded from the Medicare benefit package, or they're a procedure that's not reasonable or necessary, services not appropriate for the outpatient setting, those types of things. That's how they'd end up under there. And that includes the inpatient-only procedures. You may have heard about those. Those are procedures that, based on their nature, they cannot be performed in an outpatient setting. They're expected to be in an inpatient setting. This list is updated annually. You can find it again in the Federal Register, and those are ones that they have an SI of C. So let's talk about OPPS provisions, and this starts at the bottom of page 163. There's discounting. Some SIT procedures are discounted when multiple procedures are performed during the same encounter. We talked about that, where the first procedure is 100%, all others are 50%. Make sure that you are very aware of that. Interrupted services, if they use modifier 73 because the surgery has been discontinued, that's 50% payment. Example, modifier 74, it's discontinued after an anesthesia. That's 100% payment rate. Modifier 52 is reduced or discontinued at the physician's discretion. That's a 50% payment rate. High cost outliers, these, when the cost exceeds 1.75 times the APC payment and the cost exceeds the APC payment plus a fixed dollar threshold and an outlier add-on payment is made. So you've got the add-on payment that's 50% of the cost that exceeds the 1.75 times the APC payment. And I don't think they give us an example of an outlier payment. They don't walk us through it. I mean, there's some information in there, but they don't actually give us an example of that, unfortunately. Rural hospital adjustment. Hospitals that by reason of factors such as isolated location, weather conditions, travel conditions, or absence of other hospitals, and is the sole source of patient hospital services available to individuals in a geographic area, meet the criteria for sole community hospitals, and they get a 7.1% increase. Cancer hospitals also get an adjustment. They have a facility-specific adjustment to help because of higher payment to cost ratios than average facilities because of the cancer care that they provide. And then you have pass-through payments. These are an exception to Medicare PPS. They're for high-cost supplies and excluded from packaging under OPPS. They include pass-through drugs and biologicals with an SI of G. They're paid via APC based on the average sale price. It also includes pass-through devices with an SI of H. And again, those are paid at a reasonable cost. Other OPPS provisions we need to be aware of include hold harmless. And this is a mechanism for hospitals to decrease the financial burden of the implementation of OPPS. This was a phase-in period that provided transitional outpatient payments. Those began in 2000. They were discontinued in 2003. But they sort of transitioned into hold harmless payments, and those were for IPPS exempt cancer centers and children's hospitals. So when you think hold harmless, think cancer centers and children's hospitals, the ones that aren't involved in IPPS. They receive a quarterly interim hold harmless payment that provides additional reimbursement when the payment received under OPPS is less than the payment the facility would have received for the same services under the prior reasonable cost-based system. The hold harmless amount is determined at the settlement of the cost report. So, and of course, the hospital has 5 months after the end of their fiscal year before they submit their cost report, and from there, then CMS works out what their payment will be, what their additional payment will be. So how do you figure out how the OPPS system works? On page 167, figure 7.16 goes through how this is based. So step 1 is adjusting for geographic factors. Step 2 is adjusting for the complexity of service. And step 3 is are any policy adjustments that qualify, because not all of them do. And that walks you through all these different things we've been talking about, such as conversion factors and geographic factors and APC relative weights and rural SCHs and hold harmless and all of that, and also high cost outliers. They also are directing you to look at some figures of examples for wage index and adjustment formulas, simple calculation of OPPS payment, complex calculation of OPPS payment, and these are on page 168 in your textbook, and you can walk through those. So that is it for OPPS. We will be back with lecture number 4, which is on ambulatory surgery centers, or ASCs, shortly.